California, San Francisco. The title, I think, is perhaps because mindfulness has Eastern traditions involved. At least that's my hypothesis. But I'm going to be speaking today about the Practicing Alternatives to Heal Depression study, which is a randomized controlled trial that we have completed and are in the process of analyzing a wealth of data from, that compared mindfulness-based cognitive therapy to an alternative for treatment-resistant depression. And the question really was, is mindfulness-based cognitive therapy an efficacious augmentation strategy for reducing depressive symptoms in adults with treatment-resistant depression? And treatment-resistant depression we defined as failing to remit with 2 or more antidepressant trials, which is a common way of defining it. It can be defined in various ways, but that's the one we used. And was it more effective than the comparator condition, which I'll describe in a moment? The comparison was the health enhancement plan, health enhancement program, which compares to mindfulness-based cognitive therapy to be structurally equivalent. They both are 8-week interventions. They both are group-based. This teaches skills in mindfulness, such as how to complete a body scan or sitting meditation. This is psychoeducation-based with emphasis on physical fitness and agility, nutritional counseling, and music therapy. And whereas the mindfulness-based cognitive therapy has elements of mindfulness meditation primarily with some CBT elements. And so there are exercises in both. There's 2 hours and 15 minutes each week for 8 weeks. And here the participants do things such as a sitting meditation, a body scan, and 3-minute breathing spaces, and some exercises dealing with recognizing thoughts as not being facts. Here they do things such as walking, agility exercises, food journaling, drumming to music, and some imagery. And each of these has homework. Here it's doing meditation. Here it's doing things like journaling what your daily food intake has been. And they're both run by 2 licensed clinicians who are very experienced in mindfulness. And here they're run by experts in physical fitness, nutrition, and music. So the study design is basically a single blind study where people had a telephone interview, were screened. If they appeared to meet the criteria, they had an intake interview, and then if they met all the criteria and wanted to participate, they were randomized either mindfulness-based cognitive therapy plus their medication management, which was ongoing, or the health enhancement program. And the primary outcome was a % reduction in the HAM-D score. And then we followed other factors out to actually 52 weeks. So the inclusion criteria, just to hit the high points, are that the individuals had to meet the criteria for major depressive disorder, not be psychotic, not be cognitively impaired, and have a minimum HAM-D score, HAM-D17 score of 14 or higher. And they had to be in medication management and not have a substance abuse problem. And they had to be taking antidepressants upon entry and not be having a current meditation practice or yoga or an extensive yoga practice. So this is our consort diagram. We actually screened about 1,100 folks. 229 appeared to meet criteria, and we ended up randomizing 173 participants into the MBCT and HEP components. Now, this is the demographic characteristics. There was essentially no significant difference between these groups on any of these variables. I'll just highlight a couple of things. The age range was 45 to 47 for the mean, and it was a largely Caucasian group. There was some diversity just on the basis of where our operation is located, and about 20% of the folks were disabled. This slide highlights some of the clinical characteristics. These people had started to have depression very early in life, 19 years old or 21 years old in the HEP group. They had averaged 3.6 episodes. And here's something to be tuned into. The average length of their current episode was 84 months or 78 months. No significant difference, but I mean, it highlights in treatment-resistant depression, these folks had been suffering a long time. And their scores, the entry criteria was 14, but actually they were well above that. They had scores of 18 for the MBCT group and 17 for the HEP group. So these people were quite ill. Many had a hospitalization or a suicide attempt. So these were some challenging folks who had, as I say, been suffering for quite a long time. Here's the highlights of the clinical trial. On our primary outcome, percent reduction in the HAM-D, you can see that the people in mindfulness-based cognitive therapy had a significantly greater reduction than the people in the health enhancement program. And similarly, for the percent responding, the people with, actually the colors are reversed here for some odd reason, but these are the people in MBCT who had a higher percentage responding than the individuals with the health enhancement program. I should say the health enhancement program was a very powerful comparison because it had exercise, the music therapy, and people who took it enjoyed it quite a bit. So it was not a inactive control group. However, in terms of remission, the MBCT was higher than the HEP group, but not statistically so. So there was a trend in that direction. And of course, this population who are treatment resistant, getting people to remit is a challenge. So it wasn't surprising that we had this result. So in conclusion, we found that both MBCT and HEP had some effects in reducing depression severity. MBCT was significantly more effective than HEP after 8 weeks in overall percent change in baseline HAM-D scores and in measures of response, but not statistically superior for remission. There are limitations in the study. These are a few highlights. There could have been some variation in the antidepressant medications that people were prescribed. However, when we analyzed this, it turns out there was no significant difference in the number of medication changes over the period of the study between the two conditions. No changes in increases, decreases, or cessations. And it might have been useful to have a third arm, a weightless control. We decided not to have a weightless control because we felt it was a very weak comparison. So we used the HEP program, but one might say it would have been useful to have a third arm and see what the effects of time were on this group. But we wouldn't expect them to be great in this treatment-resistant population. And we also did not get a measure that we thought of partway through, and that is ask people before they were randomized which one they preferred and see if that was a significant factor in the outcome. However, we did have treatment expectancy after the first session, and the people in the HEP and the MBCT had equivalent expectancies of benefit from the intervention. So we don't think this was a very significant factor. Now I'll get you to the fMRI component. I'm going to move through this rapidly since we don't have a lot of time. But we took a subset of folks, 44 individuals with MBCT and 44 with fMRI, and we compared them to a healthy control group. And just to orient you, we think of there being, after Dulcos and McCarthy, that there's a dorsal executive control system in the brain, particularly for our purposes today, the dorsolateral prefrontal cortex, and for the dorsal executive control system, and the ventrolateral prefrontal cortex and the amygdala as being the key ventral affective processing systems. And what we're seeing basically is that the individuals with MBCT but not HEP have significant changes with this over time. You'll see this in a moment. We studied this in several ways. Today I'm talking about the working memory task, where people are exposed in the MRI scanner to different visual cues. Then they're asked to maintain this using either a neutral or an emotionally evocative stimuli, and then asked to recall with a probe which of these two things they saw. They press a bulb, yes or no, to identify that. And then they're shown a scrambled picture as a control. You can see this is the ventrolateral prefrontal cortex, and this slide shows it better. The ventrolateral prefrontal cortex has increased activation in the TRD patients at baseline, and the DLPFC, the dorsolateral, has decreased activation. So what we think is going on is that the cognitive control mechanisms are deficient in treatment-resistant depression. However, with 8 weeks of mindfulness training, you see in MBCT a dramatic increase in these prefrontal cortex areas, and HEP, in the HEP group, you see a slight decrease. The big thing here is the change. Ideally, these would have been the same in a randomized sample, but for some reason they were different to start with. But the important thing is the change, and the MBCT had a dramatically significant change. Here's another element. This is the ventrolateral prefrontal cortex, and the ventrolateral prefrontal cortex, thank you, is thought to essentially be part of the emotion processing system and be a braking mechanism that helps the dorsolateral prefrontal cortex exert its control. And what you see here is in MBCT that the VLPFC decreases with time, whereas with the HEP group it increases, meaning that there has to be more activity in the VLPFC to facilitate the working memory recall of the objects. And the same, that was on the left side, and here again on the right. Here's a different way of presenting the same data. What you see is with the increased Hamilton reduction over 8 weeks, there is decreased amygdala exposure in the MBCT group, but not in the HEP group. So of that original slide that I showed you to orient you, what we're seeing is the VLPFC and the amygdala are decreasing with reduced depression in MBCT. This shows it again in a different way with the right amygdala. The last was the left amygdala, and although it doesn't look like it so much, there actually is a considerable difference, that this slope is greater than this slope, and significantly so, again showing that the amygdala has decreased activation in the MBCT group compared to the HEP group. This slide shows it even more, and I think it conveys the picture that the amygdala activation is decreasing. So in conclusion, relative to HEP, MBCT was associated with increased DLPFC activation, so it was reversing that decrease that we saw in the baseline area, and decreased the VLPFC. So it was, in a sense, associated with increasing the dorsal executive control areas of the brain that were decreased in TRD. In MBCT, but not in HEP, the improvement in the Hamilton rating score was associated with a greater decline in amygdala activation during working memory retrieval compared to baseline and compared to the maintain component. So you saw that in those increased slopes on the earlier slides. So MBCT in this population relative to HEP enhances the dorsolateral prefrontal cortex and reduces ventrolateral prefrontal activation during working memory performance, and improved depression symptoms in association with enhanced regulation of amygdala activity during working memory performance. So basically, we think of the mindful, this is along the lines of what we were expecting, that mindfulness-based cognitive therapy is associated with activating cognitive control areas, the attentional control mechanisms, and reducing the affective processing areas. And I'd like to thank my colleagues, Dan Mathlon, in particular our fMRI specialist, and the other folks. Zindel Siegel, many of you know, is one of the fathers of MBCT and located here in Toronto, and several of our other colleagues who were very helpful in carrying out the study. Okay, thank you. I guess we have time for a few questions.
A couple of questions, yeah. Thank you very much for a very interesting presentation. Is the data are published already, or is it in press?
It's submitted. It hasn't been published. The protocol is published, but the results haven't been published yet.
Okay, so we have to keep track. When
Hopefully it'll be soon. I mean, it's under review right now,
okay.
but you know how things are.
Question: the first screening was a telephone screening. So I was wondering, was it a population? It was not a population-based study. So what was the reason for this telephone screening? How did they create the sample, in fact?
What did the screening consist of? The screening consisted of a basic history of some of the factors, both some of the exclusionary factors like did they have any substance abuse problems, were they currently meditating, in which case they were excluded, and also a HAM-D that was performed over the phone to see if they were in the ballpark to meet the criteria or not.
And the last question, the response was 30% for the MBCT group. The response rate of the MBCT group to the treatment was 30%.
That's correct. It was 30%.
So the good news is that 30% react, but the bad news is that 70% in fact still keeps the symptoms. So
that's right. However, I should point out, in comparison, if you look at the STAR-D trial, this was